I see trees of green, red roses too. I see them blue.
Good morning. Thank you for coming. My name is Sanja. It has been 12 years since I transitioned from a role of resident to a role of attending physician. As some of you know, and some will find out, this is a very exciting and challenging time in a career of physician. Full of knowledge, you just passed the medical boards, survived all these codes in the middle of the night. You are finally ready to help and cure your own patients. One of my first patients was Mrs. M. Mrs. M was a 34-year-old woman, a refugee from Bosnia. With her husband and 2 little girls, she escaped the horrors of Bosnian war and came to America to find a better, happier life. In our first visit, she shared with me that she had a cervical cancer several years ago. She had a hysterectomy and everything was fine. Still, she made an appointment with an oncologist at Dana-Farber, just in case. 2 years later, she died. I was devastated. I still remember her husband and 2 little girls. Nobody dies from cervical cancer. Cervical cancer is a preventable disease, but not for all. In the same year, I met Mr. H. Mr. H was a 58-year-old man who had rectal bleeding for several years. 4 years prior to that, he refused the colonoscopy that was recommended to him from his primary care provider. He didn't see a doctor since then. It took me 3 visits to convince him to have the procedure. The procedure revealed colon cancer. He died 5 years later. Colon cancer is a preventable disease, but not for all. So I'm a primary care physician in Chelsea Health Center. Most of our patients are immigrants, refugees. They do not speak English. They are poor. They're not educated. Many are like Mr. H or Mrs. M. They do not know about cancer screening, or they just don't believe in it. Colorectal cancer screening rates at Chelsea were extremely low. So, what do we do? How do we prevent the cancer in this vulnerable population? I needed an answer, and there was an answer. In 1990, in Harlem Hospital, a surgeon, Dr. Freeman, realized that regardless of his surgical skills, he just cannot cure his patients. They would die. Why? These women came to him with a breast cancer when it was already spread. There was no help. He could not help and cure his patients. And he came up with an idea, a patient navigation. Within 5 years, the breast cancer death mortality at Harlem in the Black women decreased 30% with patient navigation. What is patient navigation? Who are patient navigators? I'd like to show you a video. It's a part of a video that was made for Patient Navigator Conference by Mike Gardner this year. And it shows Erica, our navigator, who will tell you what she does and who she is.
We work with patients who tend to be low-income immigrants or refugee. At one point in my life, I was part of that population. Navigating the system for them can be overwhelming, intimidating, challenging.
So, do we use patient navigation in Chelsea? Yes. We hired a woman from a community. She educated our patients, navigated them through Mass General system to obtain colonoscopy. Did we make a difference? Oh, yes. We more than doubled our screening rates. We eliminated disparities that we had. Our Latino patients are now doing better than our white patients. Colorectal cancer screening rates at Chelsea are now the same as in patients that are receiving care in private practices at Mass General. But what is happening with the vulnerable patients, with non-English patients, with minority patients that are receiving care in these private practices, that are receiving care in our health centers that don't have patient navigation? They are not doing that well. Their screening rates are still very low. So we have another problem. We have another question. How do we reach to all vulnerable patients? How do we prevent cancer in vulnerable patients in a large primary care network? With the help of population management team, we have designed an algorithm that can identify patients at high risk of not getting colorectal cancer screening, breast cancer screening, or cervical cancer screening. And now our navigators, using this sophisticated TopCare patient navigation IT tool, are navigating patients not only for colorectal cancer screening, but also for cervical and breast screening.
It gives me great joy to know that I was able to help people who, like me in the past, were vulnerable and needed someone to walk with them along the way and help them navigate the system. I know that by doing this work, I can help not only one patient, but I can affect the outcomes for patients in the community that I love.
Our study is ending in 2 months, and we will find our results. Is this a wonderful world where we can prevent the cancer in most vulnerable patients? Can we make sure that this little girl never gets cervical or colon cancer? Thank you.